Good good morning, good afternoon, good evening, whichever part of the world you are in. This is Medical Education CPD Webinar Series. A very warm welcome to all of you. This is our first CPD session of the year. My name is Dr. Naseem Naqvi. I'm a host and co-hosting with my colleague, Dr. Mansoor Ali. We have two presentations today. I'm very pleased to introduce Dr. Fahad Ahmed, who is our first presenter. He is a consultant endocrinologist in Brighton, and he's going to talk about adrenalomas. So over to you, Fahad. Thank you.
Thank you, Naseem and Masood. Thank you for inviting me to our 2002 webinar to talk about adrenal incidentuloma. My name is Dr. Fahad Wali Ahmed. I'm a consultant endocrinologist at Brighton and Sussex University Hospital. Good evening, everyone. Good morning or good afternoon, wherever you are in the world. I have nothing to disclose. And during this session, I'll briefly just talk about adrenal gland and structure and location. And after that, I'll be talking about the definition of adrenal incidentuloma, the prevalence of adrenal incidentalomas, and how this is becoming a common problem in my clinic. We used to see it not that commonly initially, I think I'll say when I started my training, but now I'm seeing that quite often, 1 to 2 patients per clinic now. So this is becoming a common problem in my clinic. And then next I will discuss how we should manage this patient with adrenal incidentalomas, and what are the key questions we need to ask when we are managing these lesions. And in order to manage these lesions, we need to have a strong multidisciplinary team available so that we can discuss difficult cases, avoid diagnostic pitfalls, and provide an effective and good patient care. So I think that everybody knows about this, that an adrenal gland is located at the top of the kidney. It has got 2 major parts, cortex, which is the outer part, and medulla, which is the internal part. Adrenal medulla produces catecholamines, and adrenal cortex produces 3 main hormones, mineralocorticoids, glucocorticoids, and androgens. And the way to remember the 3 layers of adrenal...
Fahad, can you speak, Fahad, sorry, can you speak up a little bit, because people can't hear you properly?
Okay. Can you hear me now? Can you hear me now?
Now it's much better. Yeah.
Much better. Okay.
Yeah, much better now. Yeah.
So the way to remember the 3 layers of adrenal cortex is very easy. I remember it. I think Mansoor will like it. It's GFR. So the G is for glomerulosa, which is the top layer. The middle layer is fasciculata, and the inner layer is reticularis. And glomerulosa produces mineralocorticoids, and the fasciculata produces glucocorticoids, and reticularis produces androgen. So the definition of adrenal incidentuloma is any mass which is more than 1 centimeter or 1 centimeter, which is detected on imaging performed for reasons other than for suspected adrenal disease. So this is exclude any adrenal imaging done for patients who have got the diagnosis of excess adrenal hormone, or any hereditary syndromes which can develop adrenal tumors like SDHB mutations or multiple endocrine neoplasia type 2. So these are lesions discovered incidentally for workup done for other conditions. The prevalence it can vary depending which series we look at. In general, it is around 2% of general population. And it seems to be quite low in our clinic initially, but as the cross-sectional imaging percentage or numbers are increasing for cross-sectional imaging, we are seeing more and more cases. And we can find up to 5% of adrenal incidentalomas in any abdominal cross-sectional imaging. So in 2018, there were 5 million CTs undertaken for abdomen or kind of which included the adrenal gland. So if we make 5% of that, that's quite a big number. Another problem is that our population is aging, and adrenal incidentalomas are more common as we age. So in this study, it's quite an old study. We can see that it's quite rare in patients who are or people who are aged less than 30. So the main thing is if a patient has got adrenal incidentuloma below the age of 30, I think we should basically we should investigate this more rigorously. But as we age, then this percentage increases, and it can go up to 6 to 8% in patients who are more than 70 year old. And why we need to investigate these patients, and it goes because of the etiology of these diseases. So we know around 75% or 3/4 of adrenal incident are benign. But then again, it leaves quite a big chunk, that is 1/4 of these patients who have got a problem, which could include an hormone excess like pheochromocytoma, Cushing syndrome, or Conn syndrome, or it could be a metastasis, or it could, in rare cases, be an adrenal carcinoma. So therefore, we should investigate all these patients who have got adrenal incident, that is any nodule which is more than 1 centimeter. So for any condition, when we are trying to basically decide what we need to do, we need to ask some questions. And for adrenal lesions, we need to ask, is this lesion functional or non-functional? Are these lesions benign or malignant? Do we need to do surgery? And if we are not doing any surgery, what follow-up is needed? So let's start a simple case of a 65-year-old gentleman who presented to emergency department after a paragliding accident. His trauma scan showed that there is a small left adrenal nodule, which is around 1.9 centimeters. So any question I want to answer, so is it functional or non-functional? Basically, any assessment should include a thorough history and examination. We need to look for signs and symptoms of hormone excess. I always like to do a blood pressure in my clinic. Once I've done that, I need to assess if there's any catecholamine excess. We usually do a 24-hour urine collection for metanephrines, or we can also send a plasma-free metanephrine. And the sensitivity and specificity of this, both the tests, is very good. It's more than 95%. The next thing we need to look at, we need to measure aldosterone and renin levels. Usually these are measured in patients who have got hypertension or unexplained hyperkalemia. So in those cases, we need to measure aldosterone and renin. If patient does not have these conditions, then we don't need to measure aldosterone and renin. In cases of malignancy or hyperandrogenism sign, we need to send sex steroid, which is DHEAS, 17-hydroxyprogesterone, testosterone levels, and androstenedione. We also need to assess the cortisol hypersecretion, and this is the most difficult part of assessment because quite a lot of patients can have signs and symptoms, but a normal test, or they can have a positive test, but no signs and symptoms. Therefore, the clinical judgment is very important. And then we need to use some preferred tests, or the test with dynamic test we need to use to exclude cortisol excess. My preferred option is overnight dexamethasone suppression test, which is a 1 milligram test. The 1 milligram dexamethasone is taken at 11 p.m. at night, and a blood test is done of a 9 a.m. cortisol in the morning. And it is a preferred test in the guidelines as well. We can use other tests like 24-hour urine cortisol or a late night salivary cortisol. We can use, a preferred option is 1 milligram, but we can use a higher dose because we are not looking at ACTH production. We are also only looking at cortisol production. So we can use a higher dose. So in some cases, I use a higher dose like 2 milligrams, very rarely 8 milligrams, but 2 milligrams can be used, especially in patients who are massively obese. So we can use a higher dose. Now, based on the guidelines, we can divide the cortisol status of a patient into 3 groups. That is, if the cortisol is less than 50 or more, around 50, equal to 50 nmoles per liter after dexamethasone, then it's a normal test. If it's more than 138 nmoles per liter, then the patient has got autonomous cortisol secretion. And if it's between 51 to 138 nmoles per liter, then it is possible autonomous cortisol secretion. So if the test shows that the cortisol level is suppressed, then the test is normal and no further investigation is needed from the hormone point of view. If the patient does not have a cortisol level less than 50 or equal to 50, or is more than that, then the patient has got autonomous cortisol secretion. Then in that case, we need to assess if this is clinically significant excess cortisol, and then we need to assess the comorbidities. So The more comorbidities we have already taken in our past medical history or our history taking. So the patient can have, what we are trying to look at is hypertension, type 2 diabetes, obesity, dyslipidemia, and osteoporosis. The problem is that these conditions prevalence increases with age, and some of these conditions can have a false positive test, like obesity or even type 2 diabetes. Therefore, the clinical judgment is extremely important. So in these cases, we take an individualized approach. We usually discuss the case around NDT. We can do further tests like ACTH. We can do a low-dose dexamethasone suppression test to confirm cortisol excess. We can use other modalities like 24-hour urine cortisol or late-night salivary cortisol. Adrenalectomy is only offered in patients who have got a clinically significant cortisol excess. Now, in UK, this is the practice, but I think if we are worried that the patient may not be, the patient will not attend future appointments, then we can offer them surgery in the first instance if they do not have any past medical history or it is not clinically significant. So in our case, the patient is quite slim and fit. His urine metanephrine is normal. And overnight dexamethasone suppression test shows a cortisol of 32 millimoles per liter. So that the nodule is non-functional. The next question we need to answer is that is this benign or malignant? And for that, we need to use imaging modality. So in most cases, we get a reference from patients who have had an abdominal CT scan. Therefore, we need to do a dedicated non-contrast CT of adrenal gland. And that is the most common imaging used. And the reason to use it is that most of the evidence is on that, and it's most commonly used. But we can also use magnetic resonance MRI, so MRI scan. We can use a PET scan, but these are mainly used for patients to rule out malignancy or metastasis. So the features we are looking for is the density of adrenal incidentaloma and the size and homogeneity. So what we're trying to look at is that how much fat is present in the adrenal gland. So if we look at the density, so water will have no density, which is 0. The bone will be quite high and fat will be quite low. So we're trying to measure how much fat is present in the adrenal gland. So a non-contrast CT showing a Hounsfield unit, which is a measurement of density less than or equal to 10, then the lesion is benign. We can also use MRI, which is the chemical. We can use a chemical shift MRI, looking for loss of signal intensity to see if it's a lipid-rich or a lipid-poor adenoma. In some cases, we use a CT scan with contrast, and we're looking for the washout of the contrast to see if they are lipid-rich or lipid-poor. And any washout which is more than 60%, the absolute washout more than 60%, and relative washout more than 40%, then these lesions are most likely an adenoma which is benign. As I've mentioned before that we can use FDG PET, but we usually we're looking for the absence of the presence of FDG uptake and to rule out metastasis or malignancy. The next thing then we look at is the size. So any lesion which is less than 4 centimeter, we know that more than 75% of the lesions will be benign. Then we can have a functional lesion or we can have an adrenal cancer. So we can see that it's around 1 to 2%. So the proportion of adrenal cancer in patients who have got less than 4 centimeters of adrenal lesion is quite rare. But as the size increases, we can see the percentage of adrenal malignancy increases, and it can go up to 25% in a lesion which is more than 6 centimeters. So we basically use the density and the size. So if it's less than 10 Hounsfield unit and it's less than 4 centimeters and the morphology is homogeneous, then usually it favors discharge and no further investigation if the lesion is non-functional. But if the density is more than 10 or the size is more than 4 centimeters, then it favors more towards surgery. Most of the guidelines are written a few years ago. So now after 2016, which was when the last guideline was published, new evidence is coming up that we can actually relax the density guidance to 20 Hounsfield units. And in most of the cases, the lesions are benign. So if the density is more than 20, less than 20, and the adrenal adenoma size is less than 4 centimeters, most likely the lesion is benign, and no further investigation would be further needed. So in our case, the Hounsfield unit in this case is -3. So therefore, this lesion is benign, and we don't need to do any further investigations for our patient. So what do we do if the patient is non-functional but has got indeterminate density, that is, it is more than 20? So definitely we need to do a multidisciplinary team meeting, discuss the case with our patient as well, is that what they want exactly. In some cases, we can do a CT contrast with washout. We can do interval imaging at 6 to 12 months to see if there's a size change. And if the size is changing around 5 millimeters every 12 months, then it favors more towards surgery. Even if it's increasing in size less than 5 millimeters, but if the patient is very young, let's say 22-year-old, then it may favor surgery. And in some cases, we go for surgery without any further delay, either by patient choice or are concerned regarding the lesion that could be a malignancy. I think it's important to note that if we are offering adrenalectomy for a patient whose dexamethasone suppression test has not suppressed to less than 50, then it should be undertaken with hydrocortisone cover. Then I think we're coming to the difficult question that do we need to do a biopsy? I think the simple answer is almost never. I've very rarely recommended biopsy, and usually it's done with an MDT setup where we discuss the cases. The only time we have recommended biopsy is when the lesion is conclusively not benign, and we are trying to confirm extra-adrenal metastasis. We have ruled out pheochromocytoma, and histology will have an effect on the overall outcome with regards to the prognosis of the patient is good. What do we do with the bilateral adrenal nodule? It's basically, we do the similar imaging and hormone workup as per the unilateral nodule. The only thing we add is we do an 17-hydroxyprogesterone and also rule out adrenal insufficiency. Indication for surgery is again similar to the unilateral nodule, but again we need to do an individualized approach for the patient, because let's say the patient has got Cushing syndrome, then do we need to take both the glands? We may try to take a dominant gland, which is a bigger one, or we need to, if the Cushing syndrome is not significant, we can leave it or not. So the evidence is quite weak here at the moment. So I think it's just based on our MDT and the patient discussion, then we proceed here. What do we do in patients who have got extra-adrenal malignancy, like lung malignancy, abdominal malignancy? How do we approach this? I think the first question you need to ask is that will any investigation help the patient? If the patient prognosis is very poor, then in my view, then no further investigation is needed. If it's going to help the patient, then we need to rule out that is it benign or indeterminate. So definitely a CT scan would be helpful to make sure that the size and the Hounsfield criteria we look at to make sure that it's benign or indeterminate. If it's benign, then we go for the hormone evaluation, and then based on that, we manage the patient. If the lesion is indeterminate, we rule out pheochromocytoma. We either go for FDG PET, or do we need to do any histology or not? And is it going to be helpful for the patient to do all these investigations? Either we offer resection, or we manage it as a primary malignancy, depending on the patient condition. I think this is quite an interesting new development which we have started using. This is a urinary steroid profile, and basically this uses a technology of mass spec where it assesses the urine adrenal metabolites, and it uses the machine learning to basically have a fingerprint of the urinary steroids to say that is this adrenal carcinoma or not. The sensitivity and specificity is very high. And if we use this with the density and the size criteria, the sensitivity and specificity is further increased. So this is actually patented in Birmingham, one of the researchers from Birmingham University. And I think it's now becoming more and more commonly used in our clinical practice. And in the end, I think I'll present a case that if we do not investigate adrenal incidentuloma, what can happen. So we've got this 55-year-old gentleman who was diagnosed with oral cancer. He had no other medical problems. He underwent surgery for his oral cancer, and halfway through his surgery, he developed hypertensive crisis and had myocardial infarction. He actually had a full body CT chest abdo-pelvis, which also reported that there is a 6 centimeter irregular lesion in the abdomen between the right adrenal gland and IVC and the diaphragm. Actually, this was an adrenal incidentuloma, but no action was taken at the time because everybody was very focused on the oral cancer. The patient actually had a CT abdomen done 5 years ago, and this was present 5 years ago as well. And the size of the lesion was 4 centimeters. The patient had a 24-hour urine collection, which basically showed that the patient has got a diagnosis of pheochromocytoma, and all other investigations were normal, like overnight dexamethasone suppression test and renal aldosterone. We also did an MIBG scan, which confirmed that this is MIBG avid lesion, which is a pheochromocytoma. So this patient actually would have died had the anesthetic not picked this up, that this could be a pheochromocytoma, and the patient was put on alpha blockers immediately while during the surgery. So I think it's very important that any lesion is investigated appropriately. In most cases, the patient will be discharged from the adrenal clinic, but there is a 25% chance that they will have some significant problem, which will cause problems in the future. So in conclusion, adrenal incidentuloma is becoming much more common. And in order to manage these conditions, we need to have a multidisciplinary approach. We need to have a functional assessment and use the scan to rule out cancer. The risk of cancer is very, very low. And it only depends on which series we look at. So if you look at surgical series, the risk, the prevalence of cancer will be much more higher. But the risk of cancer in general is low. And we should use a clinical judgment and our investigation and best possible evidence to manage our patients. Thank you very much.
Thank you very much, Fahad. Thank you. Excellent presentation. So our next speaker is Dr. Sadaf Jaffer Boy. She's a consultant breast surgeon in North Midlands, UK. And Sadaf is going to talk about breast cancers. Thank you.
Thank you, Naseem and Mansoor, and good evening to the rest of you. I hope you can see my slides and you can hear me okay. So I was given the topic of about all you need to know about breast cancer, and I thought to myself, what I'm going to cover, because it's such a huge topic. So during this talk, I'm just going to talk about screening. What are the common symptoms of breast cancer? A brief introduction about triple assessment and management of breast cancer. And finally, how the COVID has impacted our services. So in the UK, the breast cancer screening takes place for women between the age of 50 and 70 years. And every woman between that age group is called once in 3 years' time to have mammography. There is a trial going on where ladies between the age of 47 and up to 73 are also being invited. And this is a part of the age extension trial to assess whether extending screening to this age group would be of any benefit. Now, in those areas where screening stops at 70, ladies do have the privilege to go and self-refer for mammograms every 3 years after they've crossed the age of 70 years. So for those of you who haven't seen mammograms before, on the screen, you can see these are a CC view. It's a craniocaudal view of the right and the left breast. And this is what screening does. It picks up something that is quite subtle, and they further investigate it. If there is any radiologist in the group, I'm sure they will know this is what we call as asymmetric density. So this is just a CC view, and in due course, I will show you what the MLO view looks like of a mammogram. So about screening, once a lady attends the screening, they have 2 mammograms on each side, which is looked by specialist radiographers and consultant radiologist. And the patient or the lady is notified about the results within 2 weeks of having the mammogram. And the results are also copied into the GP. So just for everyone to have an idea, out of the 100 women that we screen, 4 of these patients will be invited to the screening assessment unit. It doesn't mean that they have got cancer. It just means they have found something that is not quite so right and does require further investigations. And out of those 4 women, only 1 lady would have cancer. So in summary, out of 100 patients or 100 women that we screen, only 1 will be found to have a screen-detected cancer. So what are the advantages of breast screening? Now, screening is heavily criticized that it can pick things up which may not give any problem to a woman in future. So on the left, you can see without screening, if we were to screen, if there were 1,000 women, we will diagnose 58 cancers. Whereas with screening, we will diagnose 75 cancers in that cohort. Now, without screening, we know that 21 of these women will die from cancer, whereas with screening, only 16 will die. So we know that altogether, out of the 1,000 women that we would have screened, we are saving 5 lives. What we know from screening is that it reduces cancer-related deaths because screening can detect breast cancer at a much earlier stage, and majority of these women are offered breast conservation surgery. Because the cancer diagnosis is at an early stage, we know the 5-year survival rate is excellent, and we quote more than 90% of 5-year survival to these women who have screen-detected cancer. And a few years ago, there was also a study done which looked at 15-year survival. And as you can see from the screen-detected cancer have got overall 15-year survival of 86%, whereas the symptomatic ones have got a survival of 66% over a 15-year period. So moving on to the symptoms of breast cancer. Now, this is something that, I'm sure all of us have seen during our medical school or in our postgraduate training. Breast lump remains the most common symptom for breast cancer. And as you can see on the screen on the left, there is an obvious lump in the breast, in the upper pole of the breast. There is an obvious swelling. The nipple is deviated laterally. And this is a bound or symptom of breast cancer. However, sometimes patients may not feel a lump in the breast, or the referring clinician may not feel a lump in the breast, but they may have an axillary lump, which could, in other words, indicate there is something going on in the drainage area of the axillary nodes, which does include the breast. Nipple discharge is another symptom that may concern us about breast cancer. Now, every nipple discharge doesn't imply that this is cancerous, but there are certain features nipple discharge which does ring alarm bells. So if a woman has got a clear or blood-stained nipple discharge, which is uniductal, i.e. coming only from one duct of the nipple areolar complex, and it is spontaneous, those are the things that we do look out for, and we ask the patients for history with regards to these symptoms. So any nipple discharge which is clear or blood-stained, which is spontaneous and persists for more than 2 weeks, those are the patients that we would offer them surgery despite of having normal imaging. Nipple changes, we just have to bear in mind that this can be an indication or a symptom of breast cancer. As you can see on the left of the screen, the nipple is retracted, it is flatter, which is not always the case for a woman. So if they notice any changes around the nipple areolar complex, this is one of the indications for the primary care physicians to send the patient for a triple assessment. And on the right, you can see the nipple does not look right. It is dry, it is scaly. And these changes can be an indication of Paget's disease. And we do get patients referred to exclude Paget's, particularly when there are changes just around the nipple. One thing I would say that sometimes it is difficult to differentiate between eczema and Paget's, but by definition, Paget starts from the nipple and then spreads to the areola, whereas eczema is the other way around. Some ladies may have changes in the breast which are very profound and indicative of locally advanced breast cancer. And as you can see on the photographs shown on the screen, the peau d'orange is the orange peel appearance. This is where the cancer has gone into the lymphatics of the breast, as a result of which the drainage is disrupted, the skin looks thickened, the skin looks edematous. You can also see sometimes the skin overlying the breast tissue becomes red and inflamed. You can see this in an infection, but bear in mind this can be a sign of an inflammatory breast cancer, which is a locally advanced breast cancer. Other things to look out for in the skin is either dimpling or tethering of the skin. So because of all these things, some ladies do ask us if there are any risk factors per se, but we know that breast cancer is very common. In the UK, the average incidence is 1 in 8. There are certain non-modifiable risk factors, particularly the age and gender, which we cannot change, unfortunately. Early menarche or late menopause, we know, is a risk factor of developing breast cancer. If a patient or if a woman has been previously diagnosed to have atypical cells like ADH or lobular carcinoma in situ, lobular carcinoma in situ is not a precancerous condition, but it does increase the risk of developing breast cancer in future. Any family history of breast or ovarian cancer, and we take into account the first-degree relatives or a second-degree relatives before advising them about their risk for breast cancer. And of course, the inherited genes, which are the BRCA1, the BRCA2, and we also check them for something called the PALB2, which is not so new, but it's perhaps not known to everyone that this is also linked with breast cancer. On the other hand, there are some modifiable risk factors such as obesity, parity. Nulliparous women are at a higher risk of developing breast cancer, or the ones who've had their first full-term pregnancy after the age of 30. Breastfeeding is protective. Use of hormones, either in the form of oral contraceptive pills or HRT, does increase the risk of breast cancer. Or those women who've had previous chest wall or mantle radiotherapy for lymphoma, their risk of developing breast cancer is higher as compared to the average population. So we do ask this question every so often, can a woman use HRT? And if they can, how long can they use it for? What you can see on the screen, I've quoted a few studies. One is quite old, back from 2003, and that is the Million Women study that we have. We know from that the risk of developing breast cancer is higher as compared to the general population. And you can see this trend all throughout in all the studies mentioned. But also we know that the risk from combined HRT is higher as compared to estrogen-only HRT. And also the risk goes down with the duration of time. So for instance, if a lady has stopped using HRT today, after a 5-year period, her risk will go down. Whereas a lady who's currently on HRT, her risk is much higher of developing breast cancer. And likewise, if you look at the duration of it, it's a cumulative effect, which increases the risk of developing breast cancer. So what happens when a patient comes to the symptomatic clinic? We do a clinical assessment, and then we send the woman to a radiological assessment. Now, it has to be borne in mind that every woman does not require radiological assessment, particularly if they are under the age of 40 years. So if someone has got symptoms and we find there is a clinical abnormality, then we do an ultrasound scan irrespective of their age. But if a woman is over the age of 40 years, then we would do a mammogram as well. Now, either clinically or mammographically, if the lesion or the lump looks suspicious, or then we would do a mammogram, even if they are under the age of less than 40. And almost always we would do an ultrasound of the axilla if the lump looks suspicious or indeterminate at the time of assessment. We use the same criteria for men. And as you can see on the mammogram here, this is a mass lesion, and you can see the nipple is being retracted. Like I said to you at the beginning of the talk, this is an MLO view of the breast. So we do two views. One is an MLO and one is a CC view, really for us to know where exactly the cancer is, particularly in cases where the lump itself is not palpable. So at the same time, if we find there is an abnormality on imaging or clinically, we do a biopsy. This is traditionally done by a 14-gauge needle core biopsy needle. And we take a true cut biopsy, send the specimen off to the lab. This here, the curly whirly thing, is a marker clip that is inserted at the time of biopsy under imaging guidance. And the reason we do that is because then we know exactly which is the area that has been biopsied. And this is so small that the patient cannot feel it, the clinician cannot feel it, it's only visible on mammograms. In most of the hospitals or in the UK, they would have an axillary biopsy using a true cut needle if the axillary nodes look abnormal. However, if the nodes look abnormal and they're very close to the vessel, sometimes we may do an FNA rather than a true cut biopsy. And what we're interested to know is if this is cancer, what is the type, what is the grade, what are the receptors, and we bring this to MDT. Now, our MDT discussions are quite intense because what we need to decide is, does the patient need surgery? Do they need chemotherapy upfront, or can the chemotherapy be given after surgery? But we have to bear in mind that every woman with breast cancer does not require chemotherapy. And there are some targeted treatments, particularly with regards to the HER2 status. Radiotherapy, it's almost a given if someone is having a breast conserving surgery, and hormones if they are ER positive cancers. So with regards to the surgical management for breast cancer, any lady who's having an invasive tumor operated upon, they would require an axillary surgery. Now, if the nodes look normal or benign on the biopsy, we do a sentinel node. Otherwise, we do a clearance if we've got a histological evidence of axillary lymph node involvement preoperatively. Then with regards to breast surgery, and this is the discussion that we have in our MDT with the radiologist to see how extensive the disease is, whether breast conservation is an option, and if it is, then can we do something like an oncoplastic procedure to improve the cosmetic outcome? And like I said to you, if the cancer is not palpable, then can we localize it? And if so, there are different methods out there to localize this. And if the patient is not suitable for breast conservation, that means they need to have a mastectomy. Can they have reconstruction? If they can have reconstruction, should we offer them immediate or delayed reconstruction? And if they opt for a reconstruction, what are the kind of reconstruction that we can offer? So again, going back onto the mammograms. So this is a marker clip that was put in at the time of the biopsy. This is a magnetic seed, which actually enables us to localize the cancer through the skin. And this is inserted under local anesthesia prior to surgery. So when we take the area out, this is a lumpectomy specimen on the right. You can see the marker clip. You can see the seed that was inserted. And we deliberately put a couple of what we call as localization or orientation clips to tell us which side is which in case if we have to take more tissue out. And the specimen X-ray is taken at the time of operation, really to ensure that we've got good margin all the way around the cancer. So just to bear in mind, this is sort of newer techniques of breast surgery. And you cannot never tell that the patient has had surgery for cancer. On the left, this is a woman who had cancer on the right breast. And you can see after surgery, not only she's had reduction, but she had a symmetrization on the other side as well. So she's had her cancer dealt with, along with having breast reduction on both sides. Apologies for this. Now, again, we do use certain more techniques like the local flap. And in this particular patient, the tissue has been brought from the side and flipped into the breast because the tumor was somewhere out there. And if this lady puts her arm down, it will be very difficult to see where actually her scar is. And when it comes to reconstruction, as you can see, this lady she's had a skin sparing mastectomy. That means we have preserved the skin. This is where the cancer was. And underneath that, she's got an implant. So sometimes you cannot always make up from the scars what kind of operation the patient has had unless and until they volunteer the information to you. So hormones, and I think this is something that is of interest to many, and I thought I should touch base on this. With tamoxifen, we use this for premenopausal women who are ER positive. We also use them for chemoprevention and for male breast cancer. The only thing is that tamoxifen is the only endocrine treatment which is available in liquid form. But we always warn ladies about the side effects from this. Particularly, there is a small risk of developing endometrial cancer, the risk of developing DVT and PE. And it is very important for all clinicians to know this, because sometimes we get women referred to clinic to investigate why they've had a spontaneous DVT and to make sure they don't have an occult cancer. But interestingly, when you look at the drug history, you find out that they are on tamoxifen, which in itself increases the risk of DVTs and PEs. Then aromatase inhibitors, they are again another kind of endocrine treatment, which is used for postmenopausal women, either who've been treated for breast cancer or for chemoprevention. Its use in male breast cancer has not been quite studied well. That's why we don't give aromatase inhibitors to women to men as the first line of treatment. Common things to know about is that it increases the risk of osteoporosis. So almost always we do a DEXA scan for monitoring for these patients. Now, what has happened with regards to COVID-19? So screening had stopped, and all those women who could self-refer them previously, they were unable to do so. We carried out with a face-to-face appointment because triple assessment remains a part of assessment for breast cancer. Elderly nursing resident patients who were referred with suspected breast cancer, we could not assess them, but we did start them on endocrine treatment, particularly those where the primary care physician had seen them and was quite worried that this is breast cancer until proven otherwise. For our follow-ups and post-op results, we started doing remote consultations. Our MDTs, almost all MDTs became virtual, where we were documenting what the standard treatment plan would have been and how the plan has changed due to the pandemic. All the surgical services for breast cancer patients were transferred to private sector. Now, with triple negative and HER2 positive cancers, we would normally give them neoadjuvant chemotherapy, particularly the ones that were T2 cancers, but instead we went ahead and offered them surgery and then later on decided about chemotherapy. So neoadjuvant chemotherapy was only reserved for those patients where the cancer was inoperable. Those patients who were ER positive and were postmenopausal, we started them on hormones as bridging treatment while we thought the pandemic situation may get better and they will be recalled to have surgery. For DCIS, we don't always start them on hormones, but we always checked if they were ER positive DCIS. This was something new and we started them on hormones, again as a bridging therapy. Imagic reconstruction and complex oncoplastic procedures were not offered to any women during the first as well as the second wave. And recently, we started doing implant-based reconstruction only to selective women. Now, Oncotype Dx is a special test that is done to assess the risk of recurrence for breast cancer. And previously, NICE had only approved this for node-negative patients, but with the pandemic, it is now being approved for node-positive patients, and only to those who've got 1 to 3 nodes positive. For those of you who don't know what Oncotype is, it is a genetic test which tells us the risk of recurrence, and it is quite useful when it comes to advising patients about the need for chemotherapy in the adjuvant setting. Previously, radiotherapy used to be given in 15 fractions, but with COVID, we are giving it over 5 fractions. Breast cancer has always been quite research-intense therapy, and unfortunately, all the trials had stopped for at least 6 months. No benign cases were operated upon, and it is still an ongoing case. We have not been doing any risk-reducing surgeries for those who've got a BRCA1 or a BRCA2 gene. We are not doing any symmetrizing or any cosmetic procedures. So if someone is interested to know what the guidelines are on the management of breast cancer, there are a few papers out there.
Sadaf, you have 1 more minute.
Yeah, the one from the top, it is on, this is from the UK, whereas the second two are from Europe. I think I'm going to finish my talk on this, and I'll take questions if there are any. Thank you.
Okay, thank you, Sadaf. This was a very good talk. We have some questions. Mansoor, shall I ask, or are you?
Thank you very much. Thank you very much, Sadaf. That was a very great talk, actually, talking to us about everything we need to know about breast cancer. And apologies about the topic. I just could think of this topic, but I'm sure, and I knew that you will nail it, just like what you've done, really. Thank you very much for that. I have actually got quite a few questions. I was moderating the chat, so I'll start with the first question to Fahad. Fahad, are you still with us? Fahad? Okay, I'm not sure where Fahad is. So Sadaf, I'll start with you then. There is a question.
Fahad, you are muted. Can you unmute yourself, please? We can
Fahad,
see you, but we can't hear you. Fahad, you are muted. Okay.
Okay, it's all right. Can someone just actually let Fahad know that we've got a question for him? I'll start with Sadaf. Sadaf, the first question that comes to you is from Dr. Naqvi.
Fahad is unmuted now.
Is Fahad unmuted? Okay, I'll carry on with Sadaf first, and then we'll come back to Fahad. How common is breast cancer to present as pain, or how common pain as a symptom for breast cancer do you find in your cases, or from your experience, please?
So breast pain in isolation is not a symptom of breast cancer. That's the first thing. It is not unheard of, and it's not uncommon, but it is on rare occasions that we do find someone who's presented with breast pain, and because they are above the age of 40, and we do send them for a mammogram, and it's an incidental finding if we were to find a breast cancer. So that is why we say any woman who's had breast pain, it's important to examine themselves or see a primary care physician and make sure there isn't a clinical abnormality. On the flip side, it is, again, it has to be absolutely sure that the person who's examined them is confident. But having said that, any woman who's got persisting breast pain for more than 3 months should be referred to secondary care for assessment.
Okay, thank you much for that answer. And I'm sure colleagues here in primary care would heed to that advice. Another question for you, Sadaf. I think someone called Imran who's actually asking this question. My understanding, or his understanding, is screening will save 5 lives in 1,000. That is not 0.5%, but 16 unnecessary surgeries or chemoradiotherapy treatment will be given. What is the radiation dose that these patients will receive, and what is the risk of radiation-induced cancer?
So this is actually a quite good question, because we do get asked about this every so often. So in a 20-year period, so a lady would have almost 7 mammograms, which means the exposure to radiation is minimum with that. You cannot exclude the risk of radiation-induced cancer, but of course, the benefits from mammograms outweigh the risks.
Mm-hmm. True, and I would agree with that. Thank you. Fahad, actually the same question goes for you. What is the risk of medical radiation-induced cancers in the management of adrenal adenomas? Fahad, you unmute yourself. We can't hear you.
Fahad, you are muted.
There's a sign there on Fahad's name, a pin sign. What does that mean, Naseem? Is that is not
everybody is unmuted. Well,
okay.
They can unmute themselves. So they have the option to unmute themselves. Let me make him host. Maybe that works.
Okay.
Fahad, can you speak now?
No.
No. Fahad, you are the host now. So you should.
Yeah, I think we could hear him.
Yeah, now it's okay. Yeah. No, you're muted again, Fahad. Fahad, we can't hear you for some reason.
Whilst we try to sort out Fahad's, any questions, colleagues from, to Fahad and Sadaf? Tahira, Saqib, I think Saqib, we've got a question to Fahad. We'll just sort out his mic.
Can you hear me now?
Yes, we can.
Yes, I can hear you now. We can hear you now. Yeah.
So the risk of radiation-induced cancer, again, I'm not aware what is the risk as such, but we take care of how much CT scan we need to do. So if in certain patients, if we need to follow them up, we then go for, because we already know that they have got an indeterminate nodule, and we're following them up, then we probably, because we're looking at the size change, then we do an MRI scan instead. So we don't do a repeated CT scan if we can avoid it. So again, it's the risk and the benefit. So if I have to do a CT scan, I'll do a non-contrast CT, and if it's indeterminate, the next step probably will be a CT contrast with washout. And if after that I have to do any further scans, I'd rather probably go and do an MRI scan. So I won't be doing a repeated CT scan on everybody.
Okay, thank you very much.
Fahad, there is also a question about adrenal cancer diagnosis that we learned that diagnosis endocrinology, when we were studying for MRCP exams, that the diagnosis is made by blood tests and the urine tests for adrenal cancers and overnight cortisol tests and urine cortisol. So what is the role of imaging? Is it to localize the or characterize the lesion, or are we going straight to imaging in the modern era?
So imaging is important because imaging will tell you the size and the density. And again, is it heterogeneous or not? Because if the lesion is heterogeneous, the radiologist, and the size is more than 4 or 6 centimeters, and the density is quite indeterminate, so there is a fat poor lesion. It goes more towards malignancy or primary malignancy. The use in modern era, in the last 5 to 10 years, we have started using urinary steroid profile. And it's quite an important test now we use because it can actually tell us on the diagnosis that is this adrenal cancer or not. So if we use the size, the density, and the urinary steroid profile, the sensitivity and specificity is very, very high. It's closer to, I'll say, more than 95.
No, I think Fahad, the question, yeah, Fahad, the question is that for the first time, when we are suspecting, let's say, pheochromocytoma in somebody, young patient whose blood pressure has been up and down, you start with the basic urine test, isn't it?
Yes, urine metanephrines or plasma metanephrines. It depends whatever is available locally.
Yeah.
Fine.
Okay.
I hope, Saqib, if I has answered your question, I was hoping you could ask this question directly, but anyway.
Yeah, so sorry, did you want me to? Or? Yeah,
Yeah.
the reason I put the question forward firstly, thank you, brilliant talks from both. I just thought with some other people joining in, maybe some people are preparing for exams. So I thought it might be a useful tip. When we were preparing for MRCP, there was a useful tip that if an endocrine question is there and they're looking for a diagnosis, do not go for imaging, always select a blood test because imaging is only to localize. Is that still the case with modern imaging?
Sorry, can we just listen to the question? Okay. Yeah, Fahad, any?
So I think, yes, I think the question is quite a good question. So if we get a patient, let's say it's quite suggestive of pheochromocytoma, or the patient has got unexplained hyperkalemia, or the patient has got features of Cushing's, it is important to do a biochemical test first and then localize afterwards. So we need to have a biochemical diagnosis first before we do anything. So let's say if someone has got nosebleed, episodic hypertension, headaches, perspiration is suggestive of pheochromocytoma, then we do the metanephrine, urine or plasma. Once we have confirmed it on the biochemistry, then we will go and do the imaging. The same thing with patients who have got hypertension and hyperkalemia. We'll confirm by doing the renal aldosterone and then the dynamic test after that. Then we will do an imaging after that. We will not do imaging in the first go. But if we get a patient who already has got a nodule, then we have to do their biochemistry afterwards. So it's kind of the other way around. We are managing those patients.
Thank you very much. Thanks, Fahad, for a comprehensive answer. Sadaf, we've got a really great question from Hira Baba to you. If a patient is presented with benign breast cancer, what is the chance of getting cancer again? What's the benign lesion and modifiable risk factor?
Okay, so yeah, I think to be honest, I think there is a discrepancy in the question itself. One is being benign, and on the other hand,
I think guys, please can you mute all of you? Okay, I have just muted all of you because there was a lot of background noise. Guys, please, if anyone who's not speaking or asking question, please please mute yourself.
Okay, right. So to answer that question, I think probably the person just needs to clarify if it is a benign lesion, because there can be anything benign and cancer. So if it is a benign lesion, such as like a fibroadenoma, there's no risk of developing breast cancer to it. Equally, if it is a benign phylloides, which is a connective tissue tumor, there's no risk of developing cancer from it. However, if it is a malignant phylloides, they cannot develop breast cancer, but this is like a sarcoma to it. On the other hand, there is a range of changes which are benign, which I've briefly mentioned in my talk, like atypical ductal hyperplasia or lobular carcinoma in situ. Now, these are changes that does increase the risk of developing breast cancer, but they are not cancerous changes. So in those situations, ladies would require mammograms every year for 5 years following the diagnosis. I hope this answers the question.
Okay. I hope so. If they've got any queries, they can actually write in the chat box. Another question from Imran, who she asked previously about a radiation-induced cancer. So that we hear frequently surgeons undertaking unnecessary surgeries, aren't those 16 patients also having unnecessary therapies?
Okay, so like I said to you, the criticism about screening has always been because not only that we pick early stage breast cancer, but we also pick DCIS. And DCIS, we know about the nature of it. If it is low grade DCIS, this is something that may not evolve into anything sinister. And that is why the criticism has always been that you know, we are over treating these patients. But there is a trial going on, and it's been there for quite a few years, called the LORIS trial, which means for these particular low risk DCIS, can we just keep an eye on them rather than subjecting them to surgery? But you're quite right. We are doing surgeries. It's just because we don't know. There is no evidence out there as to, you know, how long can you leave them safely without any intervention.
Fahad, can I just ask you a question about, suppose I'm actually seeing a patient in the clinic, I request a CT scan, ultrasound scan, and suppose on the CT scan, this patient, for any renal or nephrology related queries, we get this adrenaloma incidental finding. Do you expect non-endocrinologists to perhaps request some hormonal tests and maybe identify the size or look into the size of the nodules before kind of referring this patient across to yourselves and the MDT? Is that the least you would expect from non-endocrinology before referring the patients across to you?
I think, thanks, Mansoor.
And because this is the last question, can I just add my question as well, if I may? For
Sure.
the incidental tumor that is not growing and not secreting any hormones, but just a small tumor there in the adrenal, can it be left and just monitored, or does it need to be removed?
Okay, both are good questions. So I think for anybody, I think the first thing I want to highlight is anybody who picks up an adrenal lesion which is 1 centimeter or more, I think the easiest thing is to refer, because we're still struggling for these referrals, and we pick them up after the patients have had hypertensive crisis or some other major problems afterwards, or they've developed diabetes as they had Cushing's 5 years ago, basically. And so it's best to refer. But I think for some people who actually, they've been practicing medicine, then it may be important to send the investigations and refer. So by the time the patients have come to the endocrine clinic, they will have probably one appointment and they will be discharged. In some big centers, they are only doing one-stop shop. So they have got an endocrine nurse who actually calls up the patients, takes a brief history, does all the investigations, all the imaging, and the patient then patient case is discussed in the MDT. The patient attends the clinic appointment and discharge in for maximum 2 appointments. And that's the case in most of the adrenal lesions, up to 75% of the case. So I think it depends how easy you feel to do the test. So overnight dexamethasone suppression test is quite easy to do. The patient needs a prescription of 1 milligram dexamethasone and a blood form to do a blood test in the morning. If the patient has got hypertension, then a renin-aldosterone test needs to be done with UNEs. But in renal patients, the problem is that they may be on dialysis. So these tests may be quite difficult to do. Urine metanephrines, if any uric patient cannot be done, so they will have to do a plasma metanephrine, which has got some logistic problems. Though what I will say is that my experience from the renal side is that they are much more geared to do these tests easily, because sometimes the hypertension team in our hospital, I've seen that they are attached to the renal team as well. So they have got much more better outpatient investigation or ambulatory investigation unit than any other specialty in our hospital. So it depends how easy it is. With regards to doing the test, it's important, especially for metanephrines, to make sure that the patient's medication is reviewed and also the dietary restrictions to be looked at. So I was referred a patient who was on dialysis. He had plasma metanephrines done repeatedly, and every dietary thing was checked by the renal team. But the thing which was not looked at, which I didn't expect them to know anyhow, it's not their fault. The patient basically—
Let me know, I need to know about it.
citrus fruit juice. So usually the thing which said not to eat citrus fruit, but the patient was having citrus juice. So because he was only allowed a certain amount, he will basically put the citrus juice in his water to drink, just to give him a taste. So as a result, his metanephrines was high. So he wasn't being put on the renal transplant list. So when the patient got referred, I stopped that and it became normal. So it's very important to make sure that the dietary restrictions are looked at and the medication is looked at for metanephrines. And again, for renin-aldosterone, that needs to be looked at. But everything is available online. So there are a lot of guidelines available from different hospitals. So your hospital will have the guidelines. So looking on the biochemistry website, you will be able to find what restrictions needs to be done beforehand. Then the question, I think, coming to Naseem's question, very good question. So I think general practice I follow, and most of the UK follow, is that if it's non-functional and on radiologically, it is completely benign and fat-rich, we discharge the patient with no follow-up. Certain guidelines or American guidelines are that they usually then do another scan after a few years. So I think there is a variation in the practice, but UK practice is that we usually discharge the patient. With regards to the biochemistry test, so if the 2 metanephrines are normal and the renin-aldosterone is normal, then we can discharge the patient. If overnight dexamethasone suppression test shows that the cortisol is gone below 50, we do not need to do any further investigations, but I do let my patients know that if they develop any symptoms of cortisol excess, like suddenly putting on weight, developing diabetes, hypertension, it's probably worth looking at that point, just to make sure that they haven't starting to develop mild Cushing or cortisol excess. If they are in the range in the middle, that so let's the case 1 I presented, where the person is quite slim, and his overnight dexamethasone suppression test is suppressed, he will be discharged from my clinic. But if his cortisol after dexamethasone suppression test, let's say, was around 105, and he does not have any signs of cortisol excess, no comorbidities, I probably will follow him up a bit more longer and do these tests on a year or 2 years basis. I sometimes, to expedite the discharge, I usually do a higher dose dexamethasone suppression test, and in that cases, majority of the patients do come back normal. But if they are not normal, then it's again patient discussion, MDT, and patient features which allow what type of follow-up is needed. Thank you.
Thank you very much.
Thank you very much.
That was really interesting. Thank you. And I think one of my nephrology colleagues will concur about the citrus fruit. Now remember that for life. Thank you. Any other questions before we call it a day? Naseem, colleagues, any other questions?
No, I think there are no questions. Thank you very much, everybody, for joining in. We had excellent talks. Thank you to both speakers. We have not
Amazing.
confirmed the speaker for February. So I think if anyone would like to present, please get in touch with Mansoor or myself. There was a question earlier about one of the CMT doctors that is it only for consultants to present? No. If you are a registrar or CMT, if you have any interesting audit or any topic, please get in touch. And because these are very global and international now, you can be from any country, any hospital, doesn't need to be working in the UK. So any trainees who would like to present on any important topics can also get in touch.
Yeah, we'll get in touch
with Mansoor or yeah, we are in various groups, international medical doctors groups. So you can post message there or connect with us. And certificates, we have shared the link already. It's a generic template with all the details of the speakers and today's program. I hope you can, all of them, you can access the link now. You just need to open it. If you have a Dropbox account, you can save it there, or it's a generic link, which was shared earlier.
Yeah, really, I would actually want to say, Naseem,
so yes, so
I think we should really encourage our GP colleagues to present, maybe because obviously we've not had a GP colleague to presenting for ever, I would say. So
yeah,
I think colleagues like Tahira, Samreen,
definitely,
it'll be great for you to come forward, and maybe colleagues actually abroad like Atia Wahid and Warda, please do email me and let me know if you're interested to present in the future. So.
Mansoor and Naseem, I've just put the link on the
I've seen
chat
that.
for the urine metanephrines. For plasma metanephrines, you don't have to do 3 days. It can be done over 12 hours or 24 hours.
Okay.
Thank
I
you.
think, Mansoor, you made a good point. Anyone from GP land, if they can talk about COVID vaccination and the challenges and the different, what's happening with the various doses and the new and the approvals and UK and all that. I think it would be good to have a session on
and
COVID vaccinations.
Maybe in primary, secondary care, we don't know what challenges GPs do go through on a daily basis. It'll be good for the GPs to just tell us their perspective. We mourn about secondary care, so it'll be nice for GPs to tell us, all due respect to everyone, primary, secondary care. We all are colleagues. So yeah, thank you. Thank you, Sadaf. Thank you, Fahad. Thank you very much.
Okay, very good.
Pleasure.
Thank you, everyone. Thank you. Bye-bye.